So I'm going to speak on a segmental meniscus loss in a multi-ligament knee injury. So we all know that meniscus is a key shock absorber in the knee, and the loss of it may lead to pain, instability, and early onset arthritis. Segmental meniscus loss can be because of either it can be post-traumatic followed by resorption of the meniscus, or it can be due to the post-meniscectomy surgery. So options available to treat the segmental loss are either allograft, which is currently a widely accepted treatment, or artificial scaffolds are also available. But the literature suggests that the scaffolds may get resolved over the time. Allograft is a currently widely accepted treatment, but we all know it's very costly and it's not easily available, especially in the peripheral part. So what about the autologous grafts? So very few articles are available about the autologous graft, few of which hardly I could find 5-6 articles which are supporting the use of autologous graft for the meniscal transplant. I could only find one article which has used the autologous graft for the segmental meniscus loss. The other articles have used it to completely transplant the meniscus. So on left side is the allograft and right side is the autograft. For allograft, the exact sizing is very important, which is not the case for the autograft. So I am presenting my case, a 24-year-old male who had an ACL injury, the PLC complex injury, along with the lateral meniscus injury. He had RTA in 2018. Since then, he had the pain was the main symptom, instability was another symptom, and he had occasional locking. But he continued without any intervention because he had a sedentary job. He is a security personnel. Mostly he has to stand or sit. So this is his, he came to me in 2023 when I got his MRI done, which suggested ACL tear, PLC tear, and you can see there is a gap in the lateral pointer. So you can see in the lateral compartment there is no meniscus. On the right hand side in medial compartment we can see nice medial meniscus, but there is an empty lateral compartment. So this is an arthroscopic intraoperative image where you can see the popliteus down there, the posterior horn is there, anterior meniscus is there, but there is a segmental loss. There is completely absent meniscus in that 2 centimeter area. So I plan to do the ACL reconstruction, PLC reconstruction, and now what to do about meniscus. Obviously I could not get my hands to allograft, and the patient was not affordable, of course. So I used the peroneus longus tendon, which was anyway harvested for the PLC reconstruction. I took as the loss was 2 centimeter, I took the 5 centimeter of peroneus longus, doubled it, so it became 2.5 centimeter approximately. And I sutured the posterior part with the posterior horn of the lateral meniscus, anterior part with the body of the meniscus, and peripheral fiber wires were sutured to the capsule. So this is not the intra video of the same patient. I could not have that video, but recently I have done another same procedure in the medial compartment. So you can see how this is how the intraoperatively the graft looks like. This is the post-operative X-ray of the patient showing ACL reconstruction, the modified Larson for PLC. Patient was kept non-weight bearing for 6 weeks. Then hinge knee brace was used, and the range of motion was started. And after 3 months, he was unrestricted range of motion was started. This is the 7-month post-operative video of the patient. Now he don't have pain. He's walking very comfortably. He's able to do squatting, and he's able to do cross leg sitting. Though 7 months is too early to say, but at least patient is happy now. This is the 7 month post-operative MRI of the same patient, and here you can see there is signal there. So the graft is in place. I can't claim that the graft has healed because it's, as I said, it's too early to say. Maybe just fiber wires are holding the graft in its place, but at least graft is in its place. MRI signals are showing it, and this is the video fat separation. Now this will clearly show this. This is the medial side, the good medial meniscus. Then the intercondylar notch. Now this is the ACL graft, the tunnels for the PLC and ACL, and now here we will see. Sorry. So here we will see the good looking meniscus in the lateral compartment. I wanted to pause the video there. So in the next section, I think there is some issue with the video. Yeah. So here now you will see, yes, here. So there is a complete continuity of the meniscus, but again, as I said, it just may be because of the fiber wires. As of now, it's just 7 months. So to discuss the segmental meniscus loss, though it is a rare entity, but may be encountered, especially in a neglected cases, the patient who have a small meniscal injury along with another ligament injury, and they continue to walk on the unstable knee, and this may lead to the resorption of the part of the meniscus. Allograft is a very costly treatment and it's not that easily available. So autologous tendon may prove helpful to replace the meniscus loss, and if it succeeds, it will be a very easily available and cheaper option. But of course, long-term and larger sample size studies are required to reach a conclusion. Thank you.